This module will focus on core conceptual frameworks of social epidemiology, and specifically will extract some of the key take-home points from Jeffrey Rose's population perspective and approach to prevention, and Lincoln Felon's fundamental causes. So a brief review of Rose's population perspective, keeping in mind that Rose's contributions are really twofold. In one hand, he's giving us insights into how we should think about etiology from a population health perspective, and also then separately giving us insights about how most effectively to intervene to improve population health. So with respect to Rose's first contribution, thinking about health from a population perspective, the key insight here is that factors explaining differences between individuals, or so-called cases, within a population may not explain differences between populations as captured by things like incidence or distribution. An extension of an implication of Rose's population perspective is that whatever is the norm in a given population is population specific, and that we can imagine and characterize a normal characteristic of a population as being something that is different or distinct across populations. And the insight of Rose here on thinking about a population as a whole, in particular this distinction between things that define or drive cases, emergent individual cases, versus population level distributions of outcomes, is really the problem of a ubiquitous exposure that within a population overall, when you characterize that population with whatever specific boundaries you choose, an ubiquitous exposure is one to which everyone in that population, however it's bounded, is exposed. And therefore, discerning the effect of that ubiquitous exposure as a driver of incidence or distribution of disease in that population is by definition impossible, because there's not sufficient variability on that exposure within the population to be able to detect its role etiologically. And what it necessitates is being able to compare across populations in order to be able to identify the role of ubiquitous exposures in driving population level health outcomes. And closely related to this is the problem of type 3 error, basically what is considered the right answer to the wrong question if you're trying to understand population level drivers of outcomes in a population, and you're only focusing on differentiation exposure within that population, you'll be potentially getting the right answer but asking the wrong question. Rose's population perspective is illustrated by this figure from his paper showing the distribution of systolic blood pressure among a Kenyan nomad population and London civil servants. And what you can see here is that the populations, while overlapping, are really differently located on the range of systolic blood pressure. If we were to try to understand the drivers of blood pressure among Kenyan nomads, we would need to appreciate the fact that what we're looking at when we consider only factors within that population may not explain its lower overall level and lower position on the distribution relative to London civil servants. And more specifically and relevant to understanding health outcomes, if we're trying to determine why civil servants in London have high blood pressure and we're only looking within that population, we will fail to realize that the entire population of London civil servants is at a higher level of blood pressure relative to this contrast population of Kenyan nomads. Rose's population approach then also gives us insights about how we might effectively try to prevent health outcomes. And he contrasts the high-risk versus the population approach to prevention. The high-risk prevention strategy simply means to screen a population to identify and target the individuals who fall above a certain threshold of risk. So your typical screening program where you categorize people as above or below a threshold of risk, and then you spend your resources targeting those who fall above that high risk or into that high risk category. And as he describes, the strengths of that approach are pretty intuitive. You can design a very tailored intervention for those who are at greatest relative risk. Those individuals, if they recognize and appreciate the risk, if it's salient to them, then they will be relatively more motivated to engage in whatever prevention strategy you're promoting compared to those who do not perceive benefit to themselves individually. As a result, you're only directing resources to those at the highest relative risk level, so it's going to be cost effective in terms of the benefits to those individuals on whom you are spending money or resources to engage in prevention strategies. And the benefit risk ratio is favorable because whatever costs or risks are entailed in your prevention strategy, they are borne uniquely or exclusively by those who stand individually to benefit. So here, visually, a high-risk strategy would simply mean that you identify some meaningful clinical threshold here. You categorize the population as above or below, and you direct your resources into this high-risk pocket of the population to engage in prevention approaches. The downsides, as Rose articulates, of this strategy are that it's often very difficult logistically and even conceptually to engage in a meaningful screening program because this distinction of where you draw that line or define that threshold point can be relatively arbitrary. And so how are you going to make a definitive cut point above which people are considered at high risk and the focus of your intervention, and the people below that threshold are relatively ignored in this strategy? And doing so and implementing a strategy, a prevention strategy that uses screening, can be fairly costly. The other insight here that kind of gets us more into the realm of social epidemiology more directly is that by focusing on just those at the highest risk level, you're really doing something that's usually more downstream, proximate to the outcomes, and is considered relatively palliative and temporary. It doesn't address the root causes being those things that are driving the overall population distribution of the risk factor of the outcome. And in a sense, you're identifying those who are at greater risk of susceptibility to a particular exposure rather than trying and intervening to diminish their susceptibility or to protect them from a bad outcome, rather than really focusing on the exposure itself that's putting that population at greater relative risk. It has limited potential for individuals and populations because of this point about it being overall at a population level relatively ineffective. And behaviorally inappropriate in the sense that, again, because the definition of a normal for a given population is population specific, if you're asking those at one end of the distribution to engage in behavior differentially from those at the other end, you're trying to ask those individuals to deviate from the norm of that population. So you can think of lots of examples about behavior-related health outcomes: drinking, smoking, eating food, etc., and how much these things are conditioned at a population level. And so when you start asking individuals to reduce their involvement in those activities, you're asking them to sort of deviate from the norms of their population. In contrast, the population strategy would be to shift the entire distribution of exposure. And here the strengths that Rose highlights are the fact that it's much more radical, dealing with fundamental causes, to use Lincoln Fellon's language. It has a greater potential for the population overall in terms of outcomes that it would affect the aggregate welfare of the population. And because you're not divorcing the tail from the mean, the intervention you're asking for is behaviorally appropriate. It's being asked of or imposed upon, if you will, the entire population. The weaknesses or limitations of the population strategy, one related to the prevention paradox, that there is more benefit to many individuals, even though at the population aggregate level, there'll be more benefit. The population paradox here referring to the fact that even though people above a high-risk threshold are themselves individually at a greater relative risk compared to others, most of the outcomes in a given population arise from the population that is not above that threshold, that is at lower relative risk, just simply by virtue of there being more of those individuals at that point in the distribution. So at the aggregate, the contribution to overall morbidity or mortality from that population is greater, even though the individuals above the threshold of risk are at greater relative risk individually. If you try to motivate the entire population, including individuals who themselves do not perceive themselves at risk, you might face weaker motivation, and weaker motivation from physicians or others responsible for intervention if they don't perceive that the benefit will be great to the individuals on whom they're intervening. And if you ask the entire population to change behavior or engage in some prevention strategy that entails risk, again, you're asking them to engage in risk or accept risk when the direct individual level benefit to themselves might be relatively small. So here visually you see that in this prevention strategy you're shifting the entire distribution from one level to another, disregarding this threshold of high risk. Okay, shifting to fundamental causes, a few key insights that we want to take away from Lincoln Felon's formulation here of a model and a conceptual framework that is really focused less on aggregate population health, although it's relevant for aggregate population level health, but more on trying to understand and think about how to prevent or mitigate inequalities, social inequalities in health. Here, a key insight related very much to Rose, the idea that risk factors need to be contextualized to understand what puts people at risks of risks. And understanding the social context that drives things like individual behaviors is very important in order to avoid ineffective interventions. The fundamental cause model seeks very much to understand and ultimately address the fundamental causes, the upstream root causes, as Rose describes them, compared to the more proximal or intervening mechanisms relative to the health outcomes. And the mechanism of fundamental causes, of course, is an enduring one and relates to individuals' ability to access and deploy resources in order to maximize their health and well-being, resources such as money, knowledge, prestige, power, and social connections. Here is my schematic illustration of an insight from fundamental causes that relates to not just the overall relationship between some upstream distal social factor like low socioeconomic status and poor health outcomes, but the insight that the relationship between socioeconomic status and health will persist over time despite changes in the intervening mechanisms between these two variables. And that's really an important insight of fundamental causes and references the enduring mechanism of resources. So it goes like this. We assume that between low SES and bad health, there are multiple channels of causation or mechanisms by which low SES translates into worse health. Smoking might be one, poor diet might be another, and because it's been in the news relatively recently, sugary soft drinks. So if we decide as public health people that we want to intervene to improve health outcomes among people with low SES or to diminish the relationship between SES and health, we might decide to develop a fruits and vegetables education campaign. Now, what this illustrates here is that if you just simply focus on education, raising awareness, and so forth, and you don't address the social context, the bigger contextual factors which have to do with resources, then you really have not successfully interrupted or blocked this chain between low SES and bad health, because you can reroute the relationship right through here by virtue of people's perhaps greater awareness about the importance of fruits and vegetables, but their inability to consume them because they are not available in their communities or they don't have sufficient financial resources to purchase them. Let's say we would then deem that as ineffective in every way. We might then decide to strengthen that intervention using insights from fundamental causes and Rose, and say that we're going to make our fruits and vegetables intervention now address structural barriers. We'll not only educate people about the importance of eating them, we will improve access through bodegas, through fresh farmers markets and so forth, or make sure there are other mechanisms by which these foodstuffs become affordable for poor people, in which case we will be effective in this goal of blocking this chain, this relationship between low SES and bad health, in terms of what the intervention is seeking to do. But what fundamental causes tells us is that we, while effective in this particular way, we won't be effective in disrupting the fundamental relationship between SES and health. And that this approach here, you see here, the line is thicker, the channel here may be blocked, but you can see other ways in which other pathways between low SES and bad health could assume a greater relative role in maintaining a relationship or if social inequalities in health. So this would not be an effective approach to reducing overall social disparities in health, because low SES will express its impact on health through other pathways. And as we intervene in various ways and successfully, we might see this relationship reproduced over time, but just through different mechanisms. So smoking is a good example. After large disparities by socioeconomic status are observed, they close somewhat, but then you still see the reproduction of social inequalities and health through other pathways. A policy implication of fundamental causes that's worth noting is another paradox here, that which points out the fact that prevention efforts can have the perverse effect of widening social disparities in health outcomes, even if they are effective in improving overall population level health. Here is a perfect example, again, back to smoking. You have here on the x-axis a deprivation score representing those who are well off, down to those who are least well off, and smoking prevalence between 1973 and 2004. And what you can see is that in 1973 there was a social gradient in smoking, where those who were poorest had higher prevalence of smoking relative to those who were least well off, with a nice graded relationship between the two. By 2004, we see that at every level of deprivation, aggregate smoking has decreased, that we've had observed a population aggregate level improvement in smoking rates in that they have decreased. But what you also see is that the social disparity in smoking between 1973 and 2004 has increased by virtue of education efforts, awareness increasing, and being much more adopted or acted upon by those with more resources relative to those with less resources. So you see the gradient here being much more steep in 2004 relative to 1973. Okay, just a way to sort of integrate and point to moments of intersection and divergence between these two models in terms of what they say about intervention. Rose's priority is more about aggregate level health improvement, with the insight that more cases actually arise from those who would be categorized as low risk. And the population level approach is more efficacious relative to high risk strategies because it appreciates social context. You're not asking the tail to be divorced from the mean. And its mechanism in the approach is to diminish the importance of individual agency. Instead of asking people to change their behavior, we change something about the policy, the population level environment that in effect does it for them. So a classic example from public health, of course, would be rather than imploring people to brush their teeth with fluoride, we put fluoride in the water, and therefore access to fluoride is not contingent on individual agency in order to access and make use of fluoride. Lincoln Felon's model, fundamental causes, is focused much more on decreasing health inequalities than necessarily overall health improvement, although the insights are very relevant to the latter. The approach to prevention is efficacious because it too contextualizes risk, but focuses a little bit more on how individual agency might be strengthened and how the disparities in access to resources is itself problematic and needs to be remedied so that individuals have sufficient access to resources in order to be able to make use of prevention health strategies.